So we have our first case, DR, born to non-consanguineous parents, presented with nephrotic syndrome at 13 years of age. There was no microscopic hematuria, no hypertension, no extrarenal features, and the renal functions were normal. The child was treated with steroids, but the child was not responsive to steroids. Kidney biopsy was advised, but it was not done. Subsequently, the child was not following up regularly and was going to multiple places where the child received a number of treatment, including tacrolimus. Eventually, the child developed CKD and progressed to end-stage kidney disease at 14.5 years of age. Child was initiated on intermittent maintenance hemodialysis at 14.5 years of age. Visited the kidney transplant center for workup, where the mother was planned as donor. So, how will you counsel them for genetic testing?
So all of the tables have the microphone with you. So
each table has one microphone, right? Yeah. Now you can.
So we'll start from this table, and then we will go around this circle. So anyone can volunteer from this table except Anil. Yeah. So how do you have a microphone?
There are no microphone in this.
Does this one not be So anyone?
So we
So
SRNS first onset at 13 years of age. SRNS did not undergo kidney biopsy, eventually developed ASKD. And now the child is now
this is I'm sure I'm audible. So this is a child SRNS late onset and has now progressed into end-stage kidney disease. So you are Sugandha is going to counsel the parents about genetic count. Like, what would you say?
The primary reasons why genetic testing might be needed in this patient is because they are being planned for a kidney transplant, where a decision of based on recurrence of kidney of the primary disease might be useful. So you would order a genetic.
So first thing the parent has to know is that why we are doing it, because we are doing it because first of all you say that SRNS high chance there is a chance of genetic, and then we are planning for a kidney transplant, so we further know about it. We should be it would be nice if we can know what sort of variant is there. If I am saying anything wrong, the experts can pitch in. Anything else that you would like to say? Nothing else.
We will
Just
our kidney biopsy or a urine sample to find out urine.
Would you take the pedigree?
Would you like to take the pedigree? Is there any other way that you can help the lab to get a correct diagnosis? So only SRNS will you do, or you?
Question is this is nothing to do with nephrology. So what is how will you counsel the parents? Or what is if you want to know anything, you can ask me. That I would like to know this, and then we will give it. Family history. So it's a genetic conference. So they would like to say pedigree, which I also don't understand. So family chapter. Accept.
So the child has an elder sister who is 21 years of age, normal. The child has two maternal uncles who also were apparently not symptomatic. The child's father had 4 brothers, of which one paternal uncle expired at 45 years of age due to cirrhosis, and the child also has 2 paternal aunts. That is all about the family history.
So that was the initial time when they kept. So it is a true case.
So which one is the index, RIA or the 20 years one?
20 years, 20 years.
No. The male is the 21 years.
Sorry, it's wrong. 21 years is the program and 20 years is the elder sister. That elder sister has some progeny.
So when the first came, initially it was not that the elder sister had initially what was told was that everybody is fair,
Mother.
and this child has gone into the ESKD, and one in that family, one person had died for some unknown reason, and another person here, I think
Yeah, the mother also has fertility.
one person here had died from kidney disease, but they didn't know, a male person. So any other that is afterward. So he has modified the slides, or someone has modified the slide. But that is afterward. So with this sort of information, that initially there was just this child who has come with ESKD now from known nephrotic syndrome, SRNS. One person in this side having died, but not from kidney disease, and one person from this side having died from kidney disease, but they didn't know the cause. Okay, from this sort of information, what next would you do? How would you function the family?
So is there any work of the system like hearing and
We don't know at that time.
what is child? The child is here.
Child, yeah, good point. So, child hearing, when we ask the family, and this is after they have been roaming around for about 4-5 years, then नहीं हमको तो सुनने में कोई problem नहीं, and the family also said नहीं अच्छा सुनता है, that's what they say. Okay, so how would you know? Don't be that way. How would you just counsel the family? That's all we want to know. And as it was told in the end that we'd like to counsel that why we are doing it. So I'm giving the answer because Subal didn't want to get why we are doing the test, and also if you remember we discussed that we have to tell them that what can be the outcome. You remember that was Asita and this was saying that what can be the outcome of the test. Outcome can be positive, outcome can be negative, outcome can be either cabinet, and we might have to do further tests. That is something that has to be given. And what are the implications of the positive test, and what are the implications of the negative test? We as a MDC, at least in India, we hardly do this. But these are the things has to be done, and that's why I always say that in an ideal situation, it should be done with a genetic counselor also.
So we need to focus what is the diagnosis also, because we don't see this is SRNS type of phenotype, initial resistance, but don't know whether idiopathic nephrotic syndrome or might be a secondary nephrotic due to familial IgA nephropathy, something else. So for that reason also we need to do the genetics for the diagnosis of the child per se, and then future
Already said that.
future
Why are we doing it? Number one for the diagnosis, number two for the transplant.
So, just to add, whenever you're ordering a genetic test, you always have a probability that how likely you are going to get a genetic etiology. For that, a few history, family history becomes very important. Only if you get a family history like this, you have already almost ruled out IgA or other. Yeah, correct. But that is a very rare situation when you take a bunch of SRNS. Younger the age of onset. If the child was like 40 years, but if it is a 5-year-old who has gone to ESKD, more likely to get a genetic etiology, history of consanguinity. If the child had some syndromic features, more likely. So just to estimate the probability also, like you rightly said, a steroid resistant can be a membranous, can be an IgA, can be a C3G. We do not know. But thorough history will help us get it.
So not only the implication of the child and the transplant, but also the donor.
Donor,
The
yes.
mother is going to be the donor.
Yes.
So what Sushmita is that also this genetic counseling should include what is the implication on the family also for the donor if the family is going to be donor. So next we wait.
just to avoid what if I say I don't want to do this, what will happen?
Very interesting question. So what if the family says that we don't want to do the genetic test, then what do you do? Would like to take that up? Any of the experts?
I mean, the third component of the counseling will be the utility of genetic testing. So it will come under 5 groups: confirmation of a diagnosis, therapeutic implications, surveillance or extra renal screening.
Yeah, but
donor
after
and
telling all that, family still
so
says
you
that
will have to explain what are the chances that you're going to get a genetic etiology. Second is implication on all this. That is, especially that you may miss a syndromic association which is subtle or which you will have to actively screen for. You may miss an autosomal dominant kind of a thing.
let us cut it short. You have explained everything, and still the family says that I don't want to do this particular scenario.
Yes.
Family says that I don't want to do the test, but you go ahead with the transplantation and mother is donor.
So we'll respect the family, but they are asking for, we respect that, telling that these are the pros and cons, that the mother might develop a disease later on if it is a extreme disorder, mother already has progenitor. Taking all this consideration, they want to do, we have to respect their
That time we go ahead with therapy. Even if they refuse the genetics, we can go ahead with therapy or transplant. Maybe some unrelated donor, maybe some known genetics negative donor. Can we go ahead for that? Even if they refuse genetics.
Yeah, it's because we are working from a guideline, so it's not, it's just a framework that you work from. It's not absolute that you have to say yes or no. I've been in that situation before, and what I would do is then put extra focus on planning for disease recurrence. So we put everything in place for disease recurrence, and then we talk a bit more about what happens to the child if the disease recurs. And then the parents sometimes will change their mind, or they will just
But there are other complications.
Yeah.
The mother in some societies is under tremendous pressure to give birth. And we are putting her at risk.
So in that situation, in the UK you have the pre-transplant team is separate, they have an interview separately, and we don't allow the transplant to go ahead. We don't always disclose the reason why to everybody else, especially if it's somebody who's being forced. We just protect them.
So we can't take mom as a donor if she refuses.
So just say this thing that when somebody refuses the genetic testing, you will have to take an assessment. Suppose it's a strong family history like this, you are likely to get this thing that you have to say. Second is many of the diseases we are not very clear. They come in end-stage kidney disease. It could be even a primary hyperoxaluria, just come there. That has immense implications. So we have to be very careful to say that okay, we are not doing testing, I'll take a consent, I will explain the risk and go ahead. You have to individualize it, and as I have said in the morning, always take a multidisciplinary, including the ethics committee of the hospital, if you feel that there is a high risk of causing something to the donor in the context of.
So our doubt is, just doubt is he refuses the genetic transplant. Can he offer a transplant? Yes or no? Can mom be offered as a donor? Yes or no? That's my answer.
Exactly, this is what I said.
No, in this patient, without the proper genetic analysis, the mother has some protein that she cannot get. There is no question of being born.
Suppose the mother doesn't have a protein.
So this is not protein, then there is a problem.
Yeah. So clinically we cannot prove that mother is in a problem. Then we have to offer them the transplant, but everything documented and as Anil said, with the multidisciplinary.
So on that note, sir, I would also like to ask one question. So suppose this patient, in whom we didn't know that the mother and the elder sister, they were having proteinuria. So if they are refusing genetic testing, then should we do a thorough workup of the other family members just to check whether there are any subtle manifestations of a genetic disease?
So what she is asking is that we will be working up mother anyway. Mother is going to be the donor, we will work up her thoroughly. She is asking that in this sort of a situation, whether we should be doing investigation in the other family member also. Normally we don't, do we? Normally we don't. Normally we don't. So normally we don't, but there is something that people discussed yesterday, that idea, maybe they should be worked.
Because we need to gather a
So
small.
we get related with the genetic base, and this is what here.
So I just read out the variants.
all can read it?
I think, is it visible from the back or should I read it out?
Master said yes.
Is it visible from that table?
So who would like to
So there are
who would like to take up the interpretation of this? So clinical exome sequencing was performed and this is the variant. And
so maybe somebody from that table, would you like to volunteer? Interpreting these variants?
how many, like, who here are the training nephrology? Anyone training nephrology? Anyone pediatric nephrology training? Not Nilari, just Nilari. Come here, come here.
Mutation in the gene code 4A5 located in exon 1 in the code in 64 position of codon where one base pair has been replaced with another, resulting in substituted C has been substituted by T has been substituted by C. C has been substituted by T. It is a hemizygous mutation. Yes.
So until now what we have said is that code for A5, the location is exon 1 and the variant is that something has happened where C has been substituted by T in the code of C dot.
Encoding sequence
I told you it's a small number, right? It's a small number, 64. So it is the 64th nucleotide from the first nucleotide of exon 1. So that A was 1. It's the 64th nucleotide from the first nucleotide of exon 1 where C is replaced by T. And what happens to the protein?
So I am again repeating myself after correcting myself. So in the exon 1 location at the 64th nucleotide. Am I right?
Yes.
Yeah. So C has been replaced by T, right? C and T are some sort of nucleotide. And for us, Indian capital, and that resulted into some change in protein, right? Now, protein.
Yeah.
It's an amino. I can't read the amino acids here. Glycine, not glycine. I don't know the amino acid. Glutamine. It is causing the synthesis of production of glutamine, causing a termination at 22.
Sorry, so this is the nonsense mutation. So ACMG criteria. Sir was explaining ACMG criteria.
A nonsense mutation is higher, right?
It becomes a strong one.
You remember ACMG criteria is the like how they are saying that how bad it is, how pathogenic. Okay.
You will show us ACMG criteria properly? ওইটা দেখা যাচ্ছিল না
We'll come to that again.
I will share it in the group, in the faculty group, so everyone will have it on the group.
Whatever it is, see suppose one amino acid is changed and the protein is long. Obviously that protein is probably what? One amino acid is changed in the termination codon. So that protein is very small. So it is a strong evidence of pathogenicity. So what is hemizygous?
X-linked.
No. What does hemizygous mean?
If it is involvement of X or Y chromosome, then it is referred as hemizygous.
Must be a male, right? So in a male, there is only one X chromosome. If there is a change, we call it hemizygous. If it is a female, if both X chromosome have the change, we call it homozygous. If one X chromosome has a change, we call it heterozygous.
Only for male.
It must be a male. Verified heterozygous. Here we cannot write heterozygous.
And this supposed to cause the disease for Alport, and because this Nephro-Genetics is supposed to be X-linked dominant.
Heterozygous means X-linked in a male. So why it is X-linked dominant? When it manifests also in females. So X-linked recessive means it does not manifest in females. X-linked dominant means also manifest in females, but males are more severely affected. So there are certain X-linked dominant conditions where male does not survive as well.
And they classified it as a pathogen. One of the reasons is that it is transmitting, it becomes nonsense.
Must be reported earlier.
Must be reported earlier. It's not present in the normal population, remember? And all our easily go to said that this is damaging.
And next,
5 out of 5.
So they have reported another mutation of the gene ADAMTS13. There is a compound heterozygous mutation involving exon 13 and exon
I
12.
understand what they said in the morning. Compound heterozygous means heterozygous.
So it can be two heterozygous mutations, which is better to tell that there are two heterozygous mutations which is likely compound heterozygous. So if it is in two different alleles, we call it compound heterozygous. Otherwise, that there are two heterozygous mutations.
So very important. Ideally, we should be saying that there is two heterozygous mutations because we still don't know whether it is cis or trans. মানে একই সাইডে দুটো ছিল তাকি
It is showing, we showed the slide, remember? We showed the cis and trans.
So if it's in cis, we don't call it compound heterozygous.
No, if it's in trans, then only we normally call it.
But then this report cannot confirm that whether it is a cis.
So this report can't. What we need to do is what we.
Okay. So and then again location is this problem is located in exon 13 and C got 1492
Nucleotide
1492
1492 nucleotides as we compare the exons from the first nucleotide of first exon.
Result.
We are omitting the introns, right? First exon, second exon, third exon, like that. Till exon 13 in this position. And in another is exon 12, it will see that the number is lesser. And both are missense mutations, right? Both are missense mutations.
No, why missense? Because
Arginine to cystine, proline to cell.
arginine has been changed, so their result has resulted into the change in protein. Arginine has been changed to cysteine and proline to serine. So that's why it is a missense. Where the previous one was a termination. TR means termination. Okay, and this is supposed to be heterozygous and is supposed to cause.
There are two mutations in the ADAMTS13.
And it is supposed to cause this hereditary
Thrombosis.
and when they classified it, one of the top one is this one is likely pathogenic. And how can I don't know? It's a
It must be reported, so the final is significant.
So this one is likely pathogenic and this one is uncertain significant. So then, thank you. You did very good. So then the question remains, what next? Who will say what next here? Parent.
And grandparents. No, see.
Please take your mind when you say.
Now, want you do a phenotyping?
That is what. If you see
Want
a
you do a
report like
phenotyping to see whether it is Alport or.
So what I is that, which I never used to do, but for the last 3-4 years I am doing it, is read the report further. The auntie sir said this in the morning, then why do they give such a long report? So what I will do is that like to read the report further. So if if we read the report further, then we have some idea. What idea?
So yeah, I read about the call for A5. The variant description says the first line, whatever already Shruti has said. So the observed variation has been previously reported in patients affected with Alport syndrome, and this variant has not been reported in the 1,000 genomes, no maybe, and our internal databases.
So this is important. All this means that this is it has not been reported before, but that doesn't mean that it is
Not been reported before in the normal
in the normal population. That 1,000 genome when they did that project etc. It has not been reported before.
You can also say it's reported in ClinVar, which means that it's the disease database.
And the in silico prediction of the variant is damaging by mutation tested 2, and the reference codon is conserved across mammals. So that is about the call for A5. Regarding the adaptase 13 variants, the first variant which was reported as likely pathogenic, the observed variation has been previously reported in a patient affected with thrombotic thrombocytopenic purpura, and the variant has a minor allele frequency of 0.04%.
So again, this is important. No? Like in the morning, Deblina was saying that what percentage of the time it can happen in a normal population, and it seems from my understanding that it is very rarely it happens in a normal population.
Yeah, it is 0.04.
কিন্তু এটাও তো আছে 0.0002
One of the population it is
আরে বাবা একটা পপুলেশন তো 0.001% হয়েছে
So whatever it is, because it is autosomal recessive condition, normal population can have a heterozygous, right? I can not jolly well carry out a heterozygous and it will be reported in normal population.
And then they did this in silico prediction which has said that it can be damaging. But again, Deblina, Kaushik, Anil will be saying that like it doesn't mean that it is pathogenic.
This is what I feel. Before we go into this variant assessment, the first thing is to look at gene disease validity. There is no point doing this exercise if you are not convinced that the child has an Adams phenotype. Because even if this shows pathogenic, both the variants, I think you will be going on a wrong track. So the first thing whenever we see this kind of report is to first establish a gene disease validity. And for that, many times the phenotypic features are expanding, where you can get, for example, in nephrotic syndromes who are resistant, they may be normal albumin but still have a podocytopathy. So something like that. So you'll have to review the literature and look whether based on this clinical feature, the XPO terms, Adams has been described. So you can go to the XPO this thing and see whether these features are described. So that will be the first step, and then go into this. That will save a lot of time.
So this expanding phenotype you can test in Decipher, you can see in Decipher, you can see in panel labs, you can also see, as sir said, like in this type and load or because sometimes these are not updated. There might be one literature which is present. So you need to do a literature survey before you are like looking at expanded.
So with that sort of information, they are saying that the first variant is likely pathogenic. Okay, and for the second variant, what they are saying is, now look here, like if we make it simple, this variant seems to be occurring in the normal population at a higher frequency, and but here also the in silico prediction is damaging, and they have classified it as VUS. So go back. So now with all this information, now someone can say what is the next step. Sumandra, you always have an answer.
Phenotype, blood, event, CBC, other activities.
So you ask for a CBC. What else? Of the child. Child already had a number of CBCs. There was never there was only one report of 80,000. Let's say 80,000. One report. But now the report when they saw was normal. Let's say normal.
I am not aware of any. It will be with only proteinuria. So I may not proceed further.
So what did you do?
Not HS.
What did you do? You go ahead with the
I
task.
may ignore these lower down reports. I will only go with the upper one reports. Only upper.
Okay. So, Dr.
What I might do, maybe one time parent, that also not help much. Might be parent testing or maybe a grandparent testing.
It is nothing but maybe. So, Sumantra is saying that he will ignore the Adam TS thing and he will go ahead with the transplantation.
So, yes.
Yes, but what else?
With respect to the call for referral.
Yeah.
For that reason, we can do parent testing for the call for referral because donor has to be most like from mother. It's
So
like
you need to test the father.
extreme dominant to might be if not symptomatic father, then probably doesn't make a sense for this one.
So then when you look at the report, what should be your next step?
So whoever is the donor coming from family, we will just if it is a female donor other than mother, we just test them and go ahead with transplant.
It is mother is the donor.
Mother can't be probably mother can't be.
Mother is the donor.
मदर को ले पाएंगे ऐसा नहीं.
हमें क्या मालूम? तो आप क्या कीजिएगा?
I think mother is out of tourism. But we will do test for mother. If mother is positive, we will out reject her.
So mother.
Yes, we have all need to reject that one.
Sorry sir.
We have all right to reject that one.
Okay, so what I understood, if I understood correctly from Sumantra, is that he doesn't want to do anything about the Adam TS mutation, and for the pole 4, he wants to do a genetics test of the mother. Remember, mother doesn't have any proteinuria at that time. Okay.
One more point is, like you mentioned, reverse phenotyping for adults. You can also do a reverse phenotyping for Alport looking at eye, even a biopsy. Sometimes you may not get it as a pathogenic. So that will give you more confidence that probably this variant is the cause of not.
So, would you do an Adam TS 13 activity?
Probably no. Probably no.
Okay, it was done. And it came as 14.8%. Okay? Can't explain.
Is it known in the literature that this type of thing can happen? I'm not sure. They need a second trigger to have a disease for PTB.
Huh?
Not sure.
So this is what happened. The Adam TS 13 was 14.8. Next.
So there will be many diseases which will manifest later.
Next.
There will be many
So
diseases.
about Adam TS, like say, I would definitely have done Adam TS anyway because.
Next slide.
Can Adam TS13 manifest later, sir? Like, that's my question, because usually if it is congenitally absent, it manifests quite early in the first decade of life.
Next. Next.
Interpretation of reports.
Does the child have ear and eye parts?
Next.
Child patient himself has
Next.
Yes, we do.
So after that, the family went around a number of places and then ultimately came back to our clinic, and we said that we want to have a reanalysis of the data by the whole exome sequencing, a segregation analysis of the family. So this will be and next.
I'll just read it out. So the call.
The new one.
It's a new one, sir.
What are these? So that has been actually missed. So in the new one, when they are saying, go back to the first original report. Yeah. No. Next. So in the new one, that is a gap of about 4 years, and they are saying this remains the same. This remains the same, and this they disappeared. The genetic people just disappeared there, same lab. And so how did that happen? So now that has been classified as benign, so they disappeared. That most probably, again, if I am wrong, you can correct me, that something must have happened during that 4-5 years where they now feel that it is likely to be a benign, right?
Yes, absolutely. Might have been reported much more in population, normal population in homozygous state, not with the disease. So when a recessive variant is found in homozygous state without disease repeatedly.
So this is purposefully I kept this case because of the importance of this reanalysis. Here a VUS can becomes benign, but they are having conditions where a VUS can become pathogenic and likely pathogenic also. Like I also was encountered.
So
Like,
even a pathogenic can become
and the pathogenic can become
normally
benign.
doesn't happen, but likely
Likely
pathogenic can
unlikely pathogenic.
Especially like in ADPKD, the number of variants that have been downscaled.
So PKD1 is one example where a number
So
of
in
variants have been
so in an ideal situation, you should be reanalyzing your data every 3 to 4 years or 2 years.
So actually, if you see the company's disclaimer, they say 6 months to 1 year. They give offer free analysis. But I don't know what's in the UK, but in the US, a lot of companies give that statement. Unfortunately, the Indian company, they remove that
No,
statement.
they charge, sir.
They charge. No,
They charge.
yeah.
Even if you order a reanalysis, they charge.
So
you
we
charge your cost. 5,000.
3 weeks is too.
3 weeks is the most
So there are two things. One is reanalysis. The other one is running the resequencing. Two things. There are two different things. So reanalysis 6 months to 1 year, and resequencing maybe in a couple of identify new genes.
And I strongly feel that unfortunately the only genetic company has gone from there. I strongly feel that it should be mandatory that they should be doing it by themselves. Why
They
should
can't do it by themselves.
Why not?
It's the clinic, sir. That's why sir said you should ideally have a lab in your own setup.
So
Ask
I
license to have a lab.
the thing
With
is,
the lab, they
they
do
become
automated
automated.
variants in a year.
They become automated.
Once.
Automatically.
it goes? Does it happen in India?
Yes, yes, yes. So
No,
internal
no, India analysis is not happening.
how many have been reported in clinic?
Who am I to? I am a
But
clinical pediatrician.
you have to report, sir. We don't report it now. That's what it is.
So that is for the delegates and the faculties also. This is a very important take home message of the fallacies of this report. Which I understood.
What happened to this patient? EDM
So now they have got only one likely pathogenic variant, and Sumatra said that he will not be worried about it. Mainly, why won't you be now worried? Like there is now one likely pathogenic in variant 18. There is only now founded this. So they have found one variant which is likely pathogenic.
So autosomal recessive only one.
So it is a heterozygous. So here Sumanta said, I will not be worried. We still did the identity as 13 and it was 10 point something. No, repeat one. Repeat.
So even lower.
10.8%, 10 point something. And then we did a full analysis of the family. By this time we got the history also. A history and the child went on saying that I hear normally. Mother also went on saying, but we did a test and the child had a bilateral sensorineural hearing loss. So child had a problem. Mother now we did a urine, had some RBCs or protein, right? Protein. No RBC, had some protein, and the sister had everything, protein and RBC.
So yeah. So this question for here, actually. So before going to the genetic test, because we are experiencing some confusion, because right now actually. So why not we fully establish the phenotype and then
Exactly. 100%.
So now the Sumanta is highlighting is that again our fault. We don't give them the full information. If we don't give them the full information, how will they do the test? So it is very important to have the full history. That was unfortunately not done before, but it was done now. So mother was carrying this gene, right? Mother was also X-linked gene was having. So question comes, number one, should we go ahead with the transplant? What do we do with the Adam TH13? And if we go ahead with the transplant, who can be the donor? So who would like to answer? Should we go ahead with the transplant? Yes or no? Huh? Yes, no.
Let's see hands. How many of you will go ahead with the transplant?
So I'm not asking for who is the donor. I'm just saying that whether
Whether you will transplant the child.
So go for transplant. Actually, we need to find out the donor.
Okay. What about the Adam TH13 10.8?
I was only bothered about the Adam TS when both the genes are positive, assuming that the unlikely, the uncertainty
means 10.8.
Yeah, 10 point. It's for a disease to occur should be less than 10. That's
5. So for a disease to occur, it is clinically significant if it is less than 5.
Remember that in autosomal recessive condition, when one allele is defective, the protein level is like it happens in.
So this family was unfortunately counseled that like we can go ahead, but there is a high chance of recurrence. But for disease to occur, it has to be less than 5. So 10.8 heterozygous, we did all of the things. So we are happy that the child should be transplanted and counseled that the chances of recurrence is low. What about who can be the donor? Mother? Father?
So the carrier in female, there is chances of problem in future. So that will be unethical for mother
So
to be
there are
donor.
guidelines for Alport also.
Yeah.
In this case, they cannot be.
So I think mother not to be included, and we will screen the donor. If it is father, that will be fine. But unless and you rule out, we say X-linked, we say same thing. But there is a chance of X-linked, the autosomal recessive and dominant. So that is not there, you can choose father.
If the child has some symptoms of this adenosis or something XYZ, so how to know these two genes are culprit, but they are coming from different the adenosis, two genes for adenosis, they are coming from mom or dad or from
Second gene ta to era.
no. Suppose this second reports are not there, and I'm
Not
just
gene is only one.
the variant, the two variants are the
Two variants.
yeah.
So likely
How
that
segregation will help here?
two variants, one is benign, no?
What is benign? Why do I need to?
That
So
is benign.
suppose we have only the first report, one is likely pathogenic and one is might be both are likely pathogenic. The child has some features of adenosis also. So how to know that both the variants are coming from single parents and they are asymptomatic? So this is just a bystander variant defect and the disease is not due to the variant itself, or this variant is causing the disease. The answer is might not be in this context, but similar context I'm asking.
So
And how to
first you do a
segregate?
Sander sequencing and then you do a phenotyping. Like you have to, like then the adaptation for this would be much, like it would not be this, right?
Okay,
For a
this
disease to
is a
occur,
gross
it will
TTP
be-
patient.
yes.
Suppose this is a TTP patient. Now, how to know this variant is causing this TTP or this variant is just a bystander?
So
Did you got my question?
yes, I did.
There is no
There is no way of doing. Like if it's
there
a
is no
way.
Alport. You are telling that the child does not have features of Alport. And
TTP.
there are some features like
TTP.
yeah. Then see, then it is the way you have done is that you do it in parents.
Exon 12 and exon 13. So suppose mom got both exon 12 and exon 13.
That is very unlikely that essentially. So they are in cis. They are in the same allele. Autosomal recessive condition, if it is in the same strand or same gene, is very unlikely that this is causing the.
And if mom has 12 and dad has 13,
So it is very likely. So there is a criterion SMG. So our US in trans with the likely pathogenic gets a point above, which will transfer it into likely pathogenic. So that is the reason you do a segregation or doing parents. You prove that they are in trans, so our US might become likely pathogenic. So two likely pathogenic disease.
Yeah. And before you make the diagnosis of this is a TTP, again seek help from the whether the clinical phenotype matches. Because if that is not there, going into this variant gene will take you through a so always think again that
So that 5 figure we should have known at the beginning after the hematology concept.
yes,
Even
yes,
when we have
yes.
those.
Okay, sorry I missed those part, but one more question was, suppose in that previous case, mother was asymptomatic, then did you take the kidney? Mother was asymptomatic, was not carrying the, carrying the gene, but was asymptomatic. Their protein is normal, blood is no blood or in the urine, no protein in the urine.
Remember that it is designated as an X-linked dominant disorder. So she is likely to have it. It is very dangerous.
What happens if it was X-linked recessive? Will you take it? So how many of you will take the kidney? Basically, you will not. So the current guideline for the Alport is saying that none of the family can donate. I mean, if they are having the kidney.
So this Alport doesn't fit into a classical Mendelian inheritance pattern. And only recessive manifest dominant has that. So X-linked homozygous. So what they say is, if it's an X-linked, the male definitely cannot donate. In female also, you should discourage donation. But in case you don't get an any alternative donor, the risk of mortality is much higher on dialysis. Then you should counsel the mother, do a biopsy, ensure that it's all normal. Even if it's normal, counsel for a probable progression or manifestation of the disease in future, and then go ahead. In autosomal recessive, again they have said the same thing, that you need to counsel them. You cannot refuse, but you can always counsel them. The first is not always find an alternate donor, but you counsel them, do a biopsy, and then go ahead with an appropriate counseling. And we did that in one of our recent family, where the mother was ineligible and father was a heterozygous carrier of the autosomal recessive. So we went ahead, did a biopsy. The biopsy actually showed thin. It was around borderline 250 something. So again here I sought the help of an expert. It was Kandai Nozo from Japan, Tokyo, who has large experience with food. He said you can go ahead with their experience. They do not reach that thing, but they gave a percentage of patients who can go to CGD. Counsel them and then no symptoms. Absolutely no symptoms. No, yeah. Second, I correct. That's a question. So the nephrologist said we just take the.
But at the moment, overall, like with the Alport, if you are affected, gene-wise.
So is it transfer sporadic revolution for Alport? Sporadic revolution for Alport syndrome. I mean, is there a certain percentage of? De novo sporadic. De novo revolution for Alport.
You can have. Yeah. So daily begins are 10 to 20, but any of the autosomal recessive, you can have de novo. In fact, if you have a de novo, your scores of scoring for pathogenicity is much higher as compared to the hereditary.
But classical X-linked disorders like Duchenne muscular dystrophy, 40% is de novo, 60% is common disease.
Alport is now becoming the commonest cause of this is the second most common genetic disease, and some says that it might even become the most common. So we do budget is the last case, and we will finish within next 10 minutes.
So this child presented with first episode of nephrotic syndrome at 7 years of age. The child had microscopic hematuria. The child also had hypertension along with that, and turned out to be steroid resistant right in the first episode. So we went ahead for a kidney biopsy that shows segmental endocapillary hypercellularity with foam cell infiltration, interstitial showing foam cell clusters, IFTA 0, IF showing C3 deposits reported as FSGS, EM reporting not done. So the child was started on CNI and turned out to be CNI resistant also. Was given injection rituximab once weekly 4 doses, and genetic cause was suspected, hence a clinical exam was sent that came out to be negative. But the child had progressively rising creatinine. Eventually CNI was stopped and child was started on MMF. The child was thereafter lost to follow-up, and then eventually the child came back with creatinine of 1.8. And then the child again presented in June 2024 with complaints of weakness in easy fatigue. Workup revealed urea of 136, creat of 7.6 with an estimated GFR of less than 15, had severe anemia, had a CKD MBD, and ultrasound showed bilateral contracted kidneys with raised echogenicity and altered CM. So what to counsel and why is it needed?
I think counseling, I think it is like we've already covered it. Almost it will be the same, but which same in the anyone wants to add anything else or the same in the previous thing, right? Same. So we know why to counsel and why we did not believe. So we directly go to the interpretation.
We will go to interpretation, not the pedigree.
Pedigree. Very important.
So parents are consanguineously married. Mother, father, and father's mother are siblings. Father has 2 sisters and had one sister who succumbed as an infant due to diarrhea and a brother who succumbed due to pneumonia. Mother does not have any siblings. Some of the pedigree is not showing here. There it is. So basically, this 13-year-old is a proband, has a 6-year-old female sibling and a 4-year-old male sibling who are apparently fine. Parents are consanguineously married, and the father's sister died at a young age due to diarrhea, and father's brother died due to pneumonia. Other than that, there was no significant family history as such. So differential diagnosis should further test be suggested, considering that once already my clinical exam was negative.
So if you go to the pedigree, this means that they are related.
Consanguineously married.
So the consanguineous married and there is this child is affected, it is still registered, right? FSPS. So it looks like highly likely to be there should be some genetic cause, but they did a clinical exam at that time previously, and it was negative. So what did it do next?
So a CNI resistant child who had microscopic hematuria, hypertension, FSGS, eventually progressed to CKD.
What next? We discussed before.
So phenotype, if you want to mark or set, if you want to
So any
family phenotype,
information on the phenotype?
The child did have sensorineural hearing loss. The child has the
So now she's saying that the child had a sensorineural hearing loss. Anything else? The child had some hematuria also.
microscopic hematuria was present right at onset.
So this child has a sensorineural hearing loss also. Family was tested?
Family initially was not tested. The clinical exam came later. After that, family was tested.
What's the family?
Yeah, so I will
Because
show.
we are going by the
Expanded
dictum, which is very important, is that we should have a clear idea of the family. So suppose we have tested the family.
So the father's urine routine is normal. The mother is 31 years old, having some microscopic hematuria, 5 to 7 RDCs per high power. Male sibling 4 years old, having 20 to 30 RDCs per high power. Female sibling 6 years without any microscopic hematuria, and there is no family history of tetanus.
So the child is affected.
And in the child, as I told, that the child had sensorineural hearing loss. HRCT temporal bone was normal. Tympanometry, audiometry planned. Eye checkup did not show any abnormality.
So what we have here is that in the family, mother is affected. has got a problem, and one of the sibling also has got a problem. But the before clinical exam was negative, right? So what now? What now? Huh? Reanalysis. I think, yeah. I mean, I was also thinking on the same line. No? Like what we learned before also is that that अगर हम हिंदी में बोलते हैं तो जो ये लोग आज बोलता है ये कल नहीं भी हो सकता है जो और हो भी सकता है ना. They go on changing their
The clinical exam was done in 2019, 2020. It has almost been 4-5 years.
It has now another 4 years has gone by. So what Kosik says today may be wrong in 4 years. May change.
Sir, just seeing on the pedigree, how could we know that that is a genetic disease? By seeing the pedigree only? Not now. Pedigree. Pedigree is the mother child. By seeing the pedigree, how could we know that this can be a genetic one? That is the reason, but not seeing the pedigree. Even if there is no consanguinity for CNI resistance, we are by default going to do a genetics. That is the reason, but not the pedigree.
Pedigree should be such.
Except for SRNS, you don't normally do this. That was the main point.
Any FSGS can have 20 to 30 RBC. They are repeatedly treated with Lasix, which is a non-autotoxic drug. It can cause hearing loss. So, just not the phenotype, but by default, we are going to do genetics, whatever may be the phenotype in this case.
So my question is,
how many SSNAs, SDNAs we have been doing randomized there? We have been doing way in maybe more than 200-300 SDNAs. I think we found
way is not a good place for that. I feel we
didn't do the Vera.
Yeah, Vera was beautiful audiometry.
There was a study from AIMS or somewhere, 10% or something like that.
my question is like if any child comes to me with SRNS, with or without family history, goes on to have CNI resistance, should I go for assessment of hearing and vision evaluation and family evaluation before I go on for genetic testing?
So where we will go directly to the genetic.
So we did a repeat testing with whole exome sequencing, and this is what it is showing.
Previously they were, so I don't know the answer of this. Maybe Kosik, Dipanjana can give the answer. That previously they didn't try anything. Now they are saying same test, clinical exam.
Whole exome this time.
And previously was
Clinical exam.
So previously was clinical exam. This one was whole exam. Previously they said nothing is there. In 4 years now they have found something of uncertain significance in whole 4A3 homozygous.
But the clinical exam previous one also covered this gene. It's not as if it's a new gene.
So the gene coverage was there, and this is still a POU area.
So previously by it was not.
Number one, we discussed Q30 can be one.
So, number one, that had it been a likely pathogenic, the answer would have been very easy. But it, one thing that it has been missed, that it had quality control was not good for that variant or near that variant, and it was never been picked up in the fight to analysis. Right? So maybe the number of hits were less, and it was never picked up for analysis. This is probably the most.
This is probably the most. The other one can be there can be variants which are around it which became significant. Like downstream, upstream variants were reported. Now this variant is coming on in the reportable variant.
Again, I guess the importance of reanalysis.
So there will be many Khaja labs which have been very less
Same labs.
Sir, as Professor previously told also that many times we find out this type of problem, but we don't report also because they are not important that time. 4 years back might be this same variant was not
No, the
what
main,
is
the main problem is the Q30.
Had this variant been reported as disease causing by some of it would have been classified as likely pathogen. Very likely. So it is US means this is still not that reported with disease.
So now with this new information, we haven't yet like this is a like this family came to us in ICH 1-3-4 days back. So we haven't done the variant analysis like because segregation analysis. We are now asking for segregation analysis. That would have been my question. That what next? Next would have been further phenotyping and segregation analysis.
So the point is, this is still a VOS. We don't know whether this is the reason for the manifestation which we are seeing. It might be Alport, but this maybe may or may not be important. That we don't know. We still don't know. So we need to do family studies.
So here segregation only doing in parents will not help.
Exactly. This is the point that
Because a VUS in trans with a VUS keeps it a VUS.
So here, that is why we need.
So it is better that we do it affected or non-affected children, parents, extended family to find out that yes, those who have some manifestation.
Sorry, sir. Can you repeat the biopsy about the affected male child in the family is there? For electron microscopy, see the
Yes, yes, absolutely.
So biopsy initially here.
No. We can't biopsy with the current child, is already in the ASRD. But there is another affected child with hematuria and protein male child. So can you go for the biopsy for that child for
So you do the variant, in that child, find it homozygous. That gives you lot of strength that this is
So current guideline in the Alport at least they are going away from the biopsy. They are going more towards the genetic. And the SIGMA is
if you don't have a clear result from the genetic, you will find out the more evidence from the other source.
If we do further.
So the idea is if we are getting a variant which is genotypically or phenotypically, the genotype-phenotype correlation is very strong. And this is a homozygous variant, it's a consanguineous family. So understand, we know the parents will be
So now
obligated
if you find the father to be homozygous, then you rule it out as.
then this is not the
If you find parents as heterozygous, another affected child also have the same variant.
Yes.
Then it becomes a strong evidence that this is the cause.
And it is one of the ACMG criteria where it is saying in the same family there are multiple affected people with same
Only a supporting criteria, but
So
it can lift it.
it can lift it
Up
up.
to
But
like
what about if this family and this one was a single child? Like we want to do affected and non-affected.
No, but there are the woman's brother is there, the man's brother and sister is there. There is always family. Like they
You
want to
don't
get
need to think of siblings. You can go for the
Yeah, that's what she's highlighting that Baba, I wanted to do something. So we'll stop here.
No, the other one which we wanted to mention over here was, when you see a VOUS which is matching, this still might not be the way. So you have to keep that in mind.
The breakdown testing, so much people will be the cost.
Yeah.
So the Sanger will not cost money.
The sample
But
is
still
the
about
cost.
7,000.
No.
4,000.
Only
No, 7,000 taka.
So a patient, the ones that we have diagnosed, we have done sequencing 4-5 years ago. If we work with reanalyze
We should
all of
reanalyze.
them, then this kind of thing will come to light.
We can.
Or is there a difference in methodology?
No. So the basic sequence is same. What they can say, the filter is different. The pipeline differs. Now normally with the standard lab, the depths are high. The problem is with labs which are not standard. Okay, like Jerome sir was.
So we break up here. We will.
I have a suggestion here. Just a suggestion. So, if suppose we select a cohort for a study, I don't know if it happened done or not. So, establish phenotype, and we need a genetic test, and how percentage you're getting pathogenic, likely pathogenic, and VUS. Because many times we are getting likely pathogenic and VUS, and then we are confused. And how clear the genetic report is coming to us, that would be important. Then My question is like that. So if you have a kid, I mean, list of patient.
Question always experts. I mean,
So actually, suppose we have a population with a established phenotypically, and we did a genetic test. What is the percent of getting pathology variant and likely pathology variant and uncertain significance? Because if we get the pathology variant, then we establish the diagnosis, and rest two we are making us confusing as a clinician.
No, so this the whole classification of disease causing variant pathogenic.
Is there any data? Is there any data like phenotypically proven disease, but genetically coming like that of pattern?
So if you see the international database, up to 80% you can identify disease causing pathogenic or likely pathogenic. But if you see the Indian whatever cohort, what they publish, the genetic yield is a little lower because many of those variants are classified as VOUS, variant of unknown significance. So that is the numbers you have to take and counsel them, saying that if I screen you, if I screen 100 children with or an adult with Alport, this is what I am going to get. So that is where so what you're talking about is the registry
in
data.
the workshop part that I think someone covered it, like when you're counseling, what percentage happens and how do you counsel?
So this is where in every disease, it's not just an Alport, even in nephrotic syndrome, you have to use the coordinate registry data and all that to see the overall yield. If you're looking at tubular disorder, you have a nice series from UK, looking at this tubular disorder and telling the yield. If you're looking at stone disease, you have to look at the yield from the large cohorts and approximately.
It's very low actually, 30%, 20%, 40%. That's likely. So genetic report confusing us a lot actually, and then the giving a good.
Right. But that is the nature of. I mean, I think we should. We are all trained to have a dichotomous thing, yes or no. But unfortunately, genetic is not like that. So we are trying to compare a usual lab with the genetic reports. It is not. It's apple and oranges, completely different, and we have to accept that.
So